Okay, so that's screening and an initial treatment for alcohol-associated liver disease. Now we'll turn to hepatitis C. Now, hepatitis C, remarkably, we still have 2.2 million individuals in the United States who are infected. And every year still, about 15,000 people are dying from hep C-related complications. And I say still because we've had highly effective curative therapies for hepatitis B for a decade now. And yet we still are challenged by patients not being aware of their infection and not getting access to curative treatment. And just to bring home that point around individuals not getting treated, these are very recent data from the CDC in which they looked at insured individuals who had either public or private insurance. They were diagnosed with hepatitis C, and then they looked to see in the next year how many of them achieved cure, and only 1 out of 3 overall had achieved cure. And so it just shows that we have so much work to do. And in terms of diagnosis, it's estimated that 1 out of 3 individuals with hepatitis C are still undiagnosed. So both in diagnosis and in treatment, work to be done. So what are the recommendations in terms of screening for hepatitis C? Well, we have very strong recommendations. USPSTF recommends that all adults aged 18 to 79 be screened once. This is not dependent on symptoms. It's not dependent on ALT levels. Screen based on just being an adult 18 to 79 years of age. And that should be done once. And then you need repeat screening for individuals who are at risk for infections. So who would those individuals be? Well, it would be individuals who are involved with injection drugs, HIV-infected men who have sex with men, individuals who, for example, get a needle stick. Anyone who's in a situation in which they might have get exposed to the virus should then be retested. And there's also 2 other special groups that there's a lot of emphasis on doing testing for hepatitis C. And one of those are pregnant women. It's recommended that pregnant women are tested each pregnancy. So even if they were tested before and they were negative, next pregnancy, they're tested again. And the reason for this is it's a really unique time to get women into care and to make sure that we're also identifying if their babies become infected. So all pregnant women need to be tested. And there's also increasing emphasis on screening individuals in the judicial system, whether jails and prison, very high prevalence of hepatitis C there. And that represents also an important opportunity for us to be able to do screening in a high prevalence population and offer treatment. How do you screen? You use an antibody test, very simple. And if the antibody test is positive or reactive, then you need to do an HCV RNA test to test for virus. In the United States, it's recommended by most experts that you would want to use a lab that actually does reflex testing. By that I mean that you order an HCV antibody, and if the antibody is positive, that they already have a second sample of blood that they can send for HCV RNA testing. That then allows the patient to make one trip to the lab and then have a diagnosis of both infection, of the antibody exposure, and if they're chronically infected. So reflex testing should be something that you look for in the lab that you're using. Once you have confirmed that someone is HCV RNA positive, that confirms they're viremic, now you're ready to start doing the initial evaluation of that patient and getting them set up for treatment. If they are somebody who is antibody negative, there isn't any additional testing to be done. If the antibody is positive, but the HCV RNA is negative, then that would be somebody who's either been treated before or has spontaneously cleared their hepatitis C infection. That individual doesn't need any further follow-up either. And once you've made the diagnosis, the management is actually quite easy, but really a little bit beyond the scope of me giving you every drug and how to use it. But really to emphasize that the approach to hepatitis C now is a test and treat approach to co-localize diagnosis and treatment, so that we have less people that are being diagnosed and falling off and not getting access to treatment. So this idea is now we do diagnosis. You just learned how, antibody and reflex testing to HCV RNA. You stage their disease, same tools that we used for MASLD, FIB4 and transient elastography to tell us what stage they are. Do they have cirrhosis, yes or no? And then treat. So we're really trying to simplify that whole cascade of care for patients. Okay, and then finally, hepatitis B. So similar to the story for hepatitis C, Part of the issue in the United States is that individuals who are infected are not yet aware of their infection. So these are data from the NHANES study, and what it shows is that about 1/3 of patients are aware of their infection, 2/3 are not. So actually we have more undiagnosed patients in terms of the proportion with hepatitis B than hepatitis C. And when we look at who has hepatitis B in the United States, it's predominantly among the foreign-born. And so the figure on the right is just showing that when we look at hepatitis B and who is infected in the United States, people who've immigrated into this country, and they've come from areas of the world where HBV is a much more endemic infection and has higher prevalence. And so Asia, Africa, parts of Europe are the key areas in which individuals with hepatitis B are now infected and undiagnosed here in the United States. We do, of course, have US-born individuals who are infected, and indeed, with the opioid epidemic and drug use, there is a risk for both transmission of hepatitis B and C. So this is another group in which we're seeing new infections. So the screening recommendations for hepatitis B changed in 2023. So in the past, we did risk-based screening. So again, we would target foreign-born individuals. We would target individuals who had risk factors for hepatitis B, but we missed the diagnosis when we took that approach. So the new approach is universal HBV screening. So similar to hepatitis C, now it's universal screening for hepatitis B. All adults over the age of 18 should have a test done once in their life. And then similar to hepatitis C, you screen all pregnant women with each pregnancy and then do risk-based screening on top of that in individuals who are engaged in at-risk behaviors. That includes high-risk sex, drug use, incarceration, etc. Now, how do you do screening here? The screening test for hepatitis B is a triplet: hepatitis B surface antigen, anti-HB core, and anti-HBs. So how do you put those triplet results together, and what do you do with them once you've done the testing? So you use the triplet. If all of those are negative, then you have somebody who's not immune and has not been exposed. So that's your opportunity to do vaccination. For the patient who's got a surface antigen that's positive and core is positive, anti-HB core, that's somebody with chronic infection. They need to be evaluated further for consideration of treatment. And then the two bottom rows here, the one is the patient who is core positive with or without the anti-HBs. That's a patient who's been exposed to hepatitis B in the past and may have antibody or may not. That's a patient who you don't have to do anything further. You just need to be aware that that patient could reactivate under immunosuppression in the future. And then finally, the patient at the bottom who has no surface antigen, doesn't have anti-HB core, but has anti-HBs, that's the patient who's been vaccinated successfully. All right. So the key one is that we're trying to identify chronic HBV. That's the group from the liver perspective that's at risk for progression, risk for cancer, risk for cirrhosis. This is the group that we're trying to identify and to get into treatment. And I just wanted to highlight that the reason we do the triplet is we really do want to identify that core positive group. So the group that doesn't have chronic hepatitis B but has been exposed to B in the past. That's why we need to do the triplet, because the anti-HB core is the marker of prior exposure to hepatitis B. Anybody who has anti-HB core has seen virus before, still has very low levels of virus in their liver, not enough to cause progressive liver disease, but the kind that can reactivate under immune suppressive therapy. And then I just can't leave the topic of hepatitis B without talking about vaccination, because this is one of the key ways that we can prevent new infections. And ultimately, if we're successful with vaccination, we will eliminate hepatitis B. So what are the vaccine recommendations? They also changed in 2023. Now it's recommended that in addition to vaccinating infants and children under the age of 19, it's recommended that all adults between age 19 to 59 be vaccinated, and any adult at 60 years of age or older who has a risk factor for hepatitis B should also be vaccinated. And the reason, again, for this shift towards doing now vaccination in adults is that, again, we recognize that we are seeing new infections in adults, primarily related to injection drug use, but also through sexual contacts. And just to finish by talking about vaccination, I want to give you a bit of an update on vaccines. A few years ago, Heplisav-B was approved, and it's an important addition to what we have available in terms of vaccines for hepatitis B, and I list them all on this slide. But what's different about the Heplisav-B is that in contrast to Engerix and Recombavax, is it's only 2 shots, 1 month apart. And the second thing is that it actually yields higher rates of anti-HBs seroconversion than Engerix and presumably Recombavax. And why? Because it has an adjuvant in it that yields higher likelihood of seroconversion. So I think it's an important new addition to the vaccine, so be aware of it. 2 shots, and really potentially a very important vaccine for groups of patients which have lower likelihoods of responding to vaccines, and that includes patients who have chronic liver disease. Patients with cirrhosis, for example, they have lower rates of seroconversion after vaccination, so having access to a vaccine like Heplisav-B is an important advance.